right, so let's get started. Thanks everybody for coming. And this we did this. Do you remember this lecture?
Well, we did it. We did the topic once before.
We did it 18 months ago.
I figure if we've been doing the lecture long enough,
Yeah.
there's only so many topics, and it's not like you can't learn something.
Yeah,
new, so.
yeah, you can learn, and I changed the cases, so it's they're a little bit different. So we're going to go over spondylolisthesis, and the word is a big long word. And last month was spondylolysis, so there was some overlap with spondylolysis and spondylolisthesis. And last month I didn't go over spondylolisthesis on purpose because I knew we were going to go over it this month. And just to go over one more time, spondylos, the Greek is just a Greek word for vertebra. Listhesis just means slip. Spondylosis just means some kind of degenerative process of the spine somewhere. It's a very non-specific generic term. Lysis means a fracture or destruction. Spondyloptosis aptosis means falling, and that by definition is when the L5 vertebra is inferior to the sacral dome. We'll get into that. And discitis, we're not going to talk about. And then the other one is Parse Interarticularis, is the area between the joints or the isthmus. And this is the isthmus of the vertebra, which is, it connects basically the posterior backside to the front side of the vertebral body. Now, why is the L5-S1 disc space so special? Well, it's one of, 27, 28 discs, but it's special because it's the biggest disc. I know that because I put a big block of bone here, and it's usually a 14 millimeter piece of bone I have to stick in. So it's the biggest disc. It's got the most lordosis, 25 degrees. It probably has the most motion, and it's lordotic where it's not lordotic in any other animal. Every other animal is kyphotic. And L5 is the biggest vertebra. And it kind of makes sense because it's got to be, because it's at the very base. You would want the base of a tower of the spine to be wide and not narrow. So that's why it's special. So just so you know what an isthmus is, an isthmus is a narrow body that connects two larger bodies. So this is a very famous isthmus. My wife and I went here for our honeymoon. PP, have you been there? Ko-PP? It's a pretty interesting place. It got decimated by the tsunami. This whole isthmus where there's like backpackers, and it was just water.
What country is that?
Thailand.
Oh,
Thailand, yeah. It's absolutely beautiful island, and you climb up this mountain and you get this beautiful view. So that's a very famous isthmus. So spondylolisthesis, you have to just keep remember, is sliding, sliding of the joints, sliding of the bones. And why is that important? Well, it's important in the spine because it's important that the bones slide, but also between the bones, the spine's segmented like this pipe. And each level is different. And in the middle are these very delicate nerves and spinal cords. You can imagine there's wires that run through this hole. So when the bones slide, the wires get kinked. And it's a serious problem for the wires or the neurological structures. So this just gives you an example. It is a column of segmented bones, and there's a tube that's connected, and there's wires that run in between. So that's why it's so important that it slides. Now, is sliding by itself a big deal? I think the answer is yes, because anytime you get a sliding of the bone, it's a severely degenerated process for that joint. It can be extremely painful. This is a man I saw last month with. Well, tell me what you see, Adam, on this MRI and X-ray. It's a patient with diabetes.
Yeah, so he's had osteonecrosis of the talus, which is the key weight-bearing bone of the foot, where it articulates with the tibia and fibula, and it's collapsed. And then also the navicular looks like it's collapsed and just anterior. So that, but one you're outlining there is the talus, and then there's the navicular just anterior to it that is also dark, so it's collapsed. And then maybe the cuboid, part of the calcaneus has that dark signal on the MRI there, and then it just anterior to that, I think, is probably the cuboid, or one of the cuneiforms perhaps, because it's more medial. But that's so there's osteonecrosis and collapse of the bone and sclerosis of the bone and huge effusion
So you can imagine like this usually probably sits here, wouldn't you say? And this thing probably sits here, and it probably slides back and forth, and it's causing this tremendous destruction of the joint. So when the bones slide or move abnormally, it causes terrific destruction of the joint, and it's usually extremely painful. But in this man, it's not, because he has a diabetic neuropathy and he can't feel a thing. That's his whole problem. Sarco joint, yeah, and it's he's had this for months, and it just got to the point where it was just too sloppy. He just couldn't walk because the limb was too sloppy, and he came in. Yeah, and very, very nice guy, actually. So, in spondylolisthesis, I almost never say the word anymore because it's too long, and I can't say it. So I just tell patients your bones are sliding. But Wiltse, and we'll get into who he is, classified it in 6 ways. Dysplastic, which is the actual form of the bones, is abnormal. Isthmic is where the main problem is at the isthmus or the pars interarticularis. Degenerative is most likely when the problem is at the discs and the facets, and then the bones slide. Traumatic is very rare, but it can happen. And usually traumatic is a pars fracture. Pathologic is if it's tumor, and iatrogenic is very common. It's when we do our decompressions, we decompress too widely, and we decompress into the pars area. And we're doing it because we're trying to help the patient by decompressing the nerve roots, but it causes a pars fracture, and then the bones slide. Or we take away too much facet, and then the facets become abnormal, and then they slide, and the patient gets spondylolisthesis. And so iatrogenic is very common. So who's Wiltse? Wiltse, in my mind, is the quintessential American. He was born in North Dakota, and he went to medical school at Northwestern in Chicago, and then he moved to California, where he was an orthopedic spine surgeon for 50 years. And he was an amazing person, and his article on spondylolisthesis was probably the first big and best description of the disease. And that's where we come up with the Wiltse classification. And he passed away in 2005, kind of recently. So what's a pars fracture? You can see the pars fracture. Well, Adam, why don't you describe it? How you look at it?
Right there at L5 on the posterior elements of L5, posterior to the facet, and right by the facet. The bone is.
So here's one facet, and here's the other facet, right?
Right. So you can see on the L4, if you go up higher, right there, you can see how that's a continuous bone going all the way up from inferior facet to superior facet. And whereas on the L5 vertebral body, you have the superior facet, and then when you come down to the bone that should be the lower facet, that it's discontinuous, and there is a lucency between there, which is a fracture.
But look at this, Adam. See how this is straight, and see how this is straight, and see how this is straight, but see how this is curved in extension?
Yeah.
So this is, in my mind, one more piece of evidence that it's lordosis at the L5-S1 segment or extension forces that cause these fractures. There's no other animal gets these. You can see that right here. See how that's like a 45, 60 degree curve.
Yeah.
These are all straight. Okay. So there's another classification which I won't get into in great detail for spondylolisthesis called the Marchetti-Lousy classification. And some people think the Wiltse classification is terrible because it confuses people. I kind of disagree. I think it's fine, but if you understand spondylolisthesis. But the Marchetti-Lousy classification is basically, they break it down to, they call it developmental versus acquired. But I think it's probably better if you call developmental dysplastic or non-dysplastic. And basically non-dysplastic are people where the anatomical structures are almost normal appearing, while dysplastic, they're very abnormal appearing. So I'll get into like this is a dysplastic case. First, the grade of the spondylolisthesis can be very high. The sacral dome is, the sacral sacrum should be flat, and yet sometimes it can be like a narrow dome, or sometimes it can be a curve like this. Look how different that looks. And then the pars interarticularis can elongate, and you can say, how can a bone elongate? Can anybody give an idea? How can a bone get longer? How can the pars elongate? Well, you keep fracturing it, it heals, and then it slips a little bit, it heals, fracture, it heals. So you're basically doing like an Alizaroff. You know how Alizaroff, you cut the bone and you spread them apart with wires? Same thing happens at the L5 pars. So in some kids, they have these really elongated pars, like, and the sacrum can get round. So this is a dysplastic case. Dysplastic cases are not so common. The dysplastic case can get so bad that the L5 vertebra can fall right over the top of the sacrum. And the sacrum in these cases usually are rounded. And you're going to say, oh, how can a bone get round? Well, this is a case of Blount's disease. And when you have excessive pressure on a growing end plate, the growth decreases. So, this is some infants get this age 3, 4, 5. So if you understand orthopedics, you can understand how this can happen as well. So anybody have any questions about sacral rounding and dysplastic bones? And then the question is, like, why does this child have a deformed bone and others don't? Why does this child have a deformed sacrum and don't? And I think no one's sure. It could be the mechanical shape of the bones. Maybe they're outliers in an abnormal shape. We'll get into that. Or it could be some kind of genetic predisposition within the end plate where the growth occurs. So this is the growth end plate. Maybe there's some kind of genetic predisposition where there's an abnormality here. Another problem is the sacral hook. So this posterior portion of the vertebra where the two facets come together can be insufficient in some people and kids, or the facet doesn't work. And you can see if this thing doesn't work, it's sort of a check ring. It stops it from going forwards because, see, the gravity forces have a tendency to make this thing slide forwards. So if you don't have a hook here or the facet's incompetent, that can cause the spondylolisthesis as well. It can be either a bony deformity or the facet capsule doesn't work. So that's kind of interesting. So these are the facts for spondylolisthesis. It's a 5% incidence at the age of 6. A lot of people have it, somewhere between 6 and 10% of adults. The only animal that gets it are human beings. It's only people who stand and walk. Eskimos get it, and that's because they do a lot of flexion extension of their spine when they clean seals. That comes from an article in Cleveland, actually, when they went over 900 specimens of anatomical specimens of bones, and they found that the Eskimos had an extremely high rate of spondylolisthesis.
Gymnasts, girl gymnasts.
Yeah, girl gymnasts and boys, wrestlers because they do a lot of extension. Offensive linemen because they extend their back. I think rowers because they forcefully extend their back. Yeah. So I think it's the forceful extension that's the key. I mean, that's controversial, but that's my theory. So this is a 73-year-old woman. All she had was right leg pain and sciatica with activity. So what do you see here, Adam?
L5 is anteriorlisthesis on S1, and there's also degenerative disc disease with loss of disc height at that level, and I think there's a little bit of remodeling to the S1. We talked about the rounding.
So here's the disc here. It looks like 15 millimeters, but here, no question, it's a lot lower, right?
Yeah.
Okay.
And then on the frontal radiograph, you get the better idea of the facets and just how sclerotic they are. That lets you know there's some hypertrophy bone there. Whereas the joint above, you can see the joint line, and even if you go up to 3, 4, you can see the nice joint line because it's not how normal it is.
Okay. So definitely abnormal. How would you read these flexion extension films?
So it looks like there is with flexion, there is some anteriorlisthesis of 5 on 1 that is reduced a little bit with extension.
By just 1 mil, I measure 8 here and I measure 9 there, and
yeah.
So not a lot though, right? Well, how would you? What's your opinion? Because you have opinions.
I would say it's insignificant. You could easily move your marker a little bit, change it by a millimeter.
Yeah, or close the other eye. How about the color of the L5S1 disc? Is this significant or no?
There's gas in there, so it's creating a gas phenomenon with extension. But I don't put a lot of. Maybe I should, but I don't put a lot of weight on that.
Okay.
It's just being extracted a little bit with extension, that it's not with flexion.
Okay, so you wouldn't even comment on it?
Um,
I'm not trying to, you know.
I think because it's not there on both, I probably would comment on it, but I'm not sure. I guess I'm not sure of its significance.
Who knows? Only God knows, maybe.
Yeah.
But okay. So
How do you put? I mean,
I'm like you. I don't have strong opinions about anything. They lead
Okay.
to wars and famine and death. Tell me. I'm sorry,
Joanne,
Joanne.
that's
Joanne.
fine.
Okay.
Never.
Um,
I also have no opinion.
what do you think? You have no opinion at all? All right.
Agreed. It's
All right. What about this, Adam? This is the X-ray, the MRI now. Sagittal
all right.
clip.
So we have a T2 MRI. The CSF is white, telling us it's T2. You can see normal fatty marrow in the vertebral bodies, and the vertebral body height is nicely preserved. The disc is degenerated and irregular, narrowed. Because of the way it's window leveled, I would assume that it's probably dried out. The nucleus pulposa in 5-1 is probably dried out, but because of the way it's window leveled, I can't be sure of that because it looks like all of them are. So that's not real good.
Can I ask you? Do you think this is dysplastic or not dysplastic? Sacrum is
I
round
think
or
it's
flat?
Not.
Yeah. So
Yeah.
the sacrum's nice and flat. The L5 vertebral body is slightly trapezoidal. I think if you look at a lot of people, it's usually 4/5. So if this is 4 centimeters, the front measures 5 centimeters. Usually, most people, 4 and 3 are usually squarish. The sacral inclination angle is about 45 degrees, which is about right. Okay. So what about the foramen, Adam?
The foramen are narrowed at L5S1 and the term I use is elongated, and that's more in like the anterior posterior dimension. You can see if you go up one to the 4-5, how it's sort of a vertical keyhole, and as you come down to the 5-1, it's angled and elongated in anterior posterior dimension. And
You use that term in spondylolisthesis, elongation of the foramen?
I do.
Okay.
Yeah.
No, I'm just curious. That's interesting.
I
All right.
do, and I think about it just because it's stretched because of the listhesis.
Right.
It's stretched, but it causes it in craniocaudal dimensions to be narrowed.
Okay.
It's kind of like if you take dough and it's a nice round thing and you stretch it in one dimension, it will thin.
Right.
Because of conservation of mass in the dough, but in here it's the same sort of thing.
Right. From the deformity.
So the deformity, so it gets narrowed in craniocaudal dimension, which can then cause for impingement of the nerve.
So it flattens the nerve root, which is in the middle of that space.
Yeah.
Okay. What about the lateral recess? Which one's better, this one or this one? This one?
That one, I guess.
You think it's lateral? You think it's compressed there?
It's narrowed, yeah. The lateral recess is narrowed as well.
So you got this osteophyte and compressing the root. And I mean, my personal opinion, I say that because I may just be a fool with my opinions, but I can't really tell sometimes on the MRI scan how much compression is on the root, because if there is any hypertrophy of the facet or capsule, the MRI doesn't tell you absolutely how much compression there is on the nerve root. I think it's because it's just not so sensitive. So sometimes, and Eric can attest to it, we go to the cases, there's a lot more compression than what we expected, and the root has a lot more room, and then we're done with decompression. The root is freed, and it's not in the same place it was before. So it's just something that, so we have to go with our clinical, sense. So this patient, I just did a decompression because Adam said in his report that there was no significant motion on flexion extension films. But during the decompression, there was a lot of motion, and the patient understood that she may fail. And sure enough, she came back, and her leg pain was worse. So I took her back very quickly, like 3 months later, for a fusion, because the motion that occurred there, although on flexion extension X-rays was not so bad, remember it was only 1 millimeter, but for her it was way too much. The nerve couldn't tolerate it. And even though I was sure I decompressed it, I was absolutely 100% sure I fully decompressed the root, maybe that even worsened it because it became even looser. So this is a case that failed for me and it required a fusion. So any questions about that?
Just we had a discussion before about fusion, and I've been trying to use terms fixation versus fusion. And for me, just because you were very much saying unless it is solid bone It's
Right.
not fused.
Right.
So therefore, the day after you do this surgery, you can't say it's fused.
No, of course not.
So because of that, I've been trying to use, it's fixed.
Spinal fixation.
It's spinal fixation, and
Yeah.
until it's bone solid.
Which you can't tell for a year, because it's like a beehive of activity within that bone for a year or two, because we know that because the bone scan's hot. So it's constantly remodeling. So you don't know for sure. So these patients' non-union pain never presents at 2 or 3 months. They always present at a year out, and that's when probably the neurofibers grow into the non-union mass and cause pain. So it's a kind of a lengthy process. So to make a diagnosis of non-union, you need a CAT scan like 6 to 12 months post-op.
Okay.
So you're right. So this is there's spinal fixation present, and I would describe it just as a fusion mass or a fusion mass. We call it fusion mass, but we're not certain that it's a fusion for like a year out.
Okay.
And we'll talk about that in 1 second. So we went over this before, but the sacrum, these are all little sacrums in patients with spondylolisthesis, and there can be all sorts of different little shapes. And some can be kind of, to see this one is kind of real dysplastic one. See, this one is angled, more vertical. We'll get into that. It has a higher pelvic incidence. See, this one's almost like straight down. You can imagine that one is a lot more likely to develop spondylolisthesis than, say, this one, which is more upright. And some of the sacrums are C-shaped and curved. Look at that. That's a very dysplastic one, isn't it? So the sacrum can have all sorts of different shapes, and just goes to show you how this shape, and you can see if the angle is very high, or there's some kind of abnormal growth problem within the end plate for the child, the person develops this dysplastic sacral dome, like Blount's disease of the tibia. These are all the different ways that we can describe spondylolisthesis. And does anybody have any questions about that? I won't get into it, because usually what do you use, Joanne, what do you usually use when you describe spondylolisthesis?
It's graded by the percentage of anterior posterior listhesis, grade 1, 2, 3, 4.
Right.
1 being 25, 2, 50,
Yes.
3, 75.
Yes, that's the, in orthopedics we call it the Meyerding classification, and it's the 25, 50, 75, and 100.
Is that okay for you?
Yeah, anything's fine. So, the Parse fractures, we call it the Scotty dog on the oblique view. The collar on the Scotty dog is the fracture of the Parse Interarticularis. And it's just, we just talk about that. Now, this is a sort of a newish term of pelvic incidence. You're like, what is that? It's like, this is, some people feel why some people slip, because the pelvic incidence is high. So the gravity line should go through your femoral head, and it should be close to the front of the sacrum. Now, if your sacrum is angled like way vertical, and you have a high pelvic incidence, you're a lot more likely to develop spondylolisthesis. And you remember, the sacrum and the hips are connected basically, because the acetabulum and the sacrum are just one bone. They don't move. So if you're born with a high pelvic incidence, you're more likely to have a shear or a spondylolisthesis. So you can be born with the deformity. So you may be an outlier in your pelvis. You're just born with an abnormal pelvis, and then you're more likely to develop spondylolisthesis compared to somebody who's not born like that. So that's like a sort of a newish parameter that came from French literature. So Joanne, what do you think? Let's do this case. What do you think of this case? Can you describe it?
So on the right, you have, I would say that's almost grade 2, anterolisthesis of L4 on L5. You have disc height loss at L4-5.
Compared to that one and that one.
And the remaining levels look normally aligned.
They look pretty good. Okay.
On the AP radiograph, you have a lot of hypertrophic change about posterior elements and facets, particularly on the left, which is the right-hand side of the screen.
Okay.
And so again,
By the way, orthopedic surgeons, we always do everything backwards. Our AP views. Did you know that? We do the AP backwards, because we look at the films as if we're operating on them. That's our convention. So this is the right for us.
Okay.
But go ahead.
All right. So again, trying to look at the lateral view and make something out of the facets and posterior elements in the back, I can't say anything clearly intelligent other than they're hypertrophic. Potentially, if we had an oblique view, we could say if there's...
Is there a Parse fracture, you think? Yes or no?
I don't know. I can't
Okay.
I would say, based on the degree of interarticularis, I'd be highly suspicious for one, but I can't call
Okay.
it.
How about, that's not too interesting. How about, here's that L4, L5. What do you think of this?
I think that is abnormal. First of all, there's circles there. And
Right.
then there's extensive amount of edema.
Right.
Whatever it is, there's edema. That's either fluid in the facet joint or that's fracture, and that's actually edema in the bone about a fracture. So,
Okay. So this is the same. Now look at the spondylolisthesis here. How much is it there? I know it's not great film, but is there a lot or is little?
Yeah,
Can you
it
tell?
does not look as impressive.
Doesn't look as, no, it's not. There's no spondylolisthesis much in the MR.
So
But
the
and then you
patient's-
have these gap facets. Yeah, so she's probably reducing.
as she's laying flat on the
Yeah,
scanner.
yeah,
That
so-
last image that you went, that one, the other one.
This one?
Yeah. So there you see edema, and potentially you can triangulate to figure out whether that's back posteriorly.
Here?
No, in a facet.
Oh, here. Yeah,
so
yeah,
that's
yeah.
not typically in a normal facet joint where you would see fluid, and that is more suspicious for a fracture.
Yeah,
Or
I don't think.
anemia or whatever, stress response, or
Okay, so it's definitely
Continuum of-
something water, but I think in this case, but I know this case, and this is a surgical case, so I know it. So and you're just looking at the images for the first time, but I know this case very well. This is just fluid within the facet joint because of a deformity. Because when she lays down, she reduces, and then there's a gap in the facets. And we know this when I reduced her intraoperatively, there was a huge. So here she is pre-op, and here she is intraop. See how she's reduced? And then intraop, there was a big gap in the facets. And I know that because I have to stuff bone in there. So this is a case where the whole deformity was through the facet joint, not the pars. So you can have a severely degenerated facet. So what I do is I look at the shape of the facets and how irregular they are, and if they should be like kind of a straightish line. But if they have this huge gapped area and they're hypertrophic, there's a lot more likelihood that the majority of the deformity is through the facets and not the pars. So, I mean, these are just mostly surgical problems, you know.
so do you treat that differently in terms of?
It depends. It depends. Yeah, you do treat it differently. Yeah, you do. We'll get into that. It's a different treatment for the way I do it anyway. Okay, how about this, Adam? A 67-year-old man with low back pain, bilateral sciatica, worse with ambulation, better when he sits.
He has a dextroscoliosis. Apex of the scoliosis is about L3.
How about lateral? Sorry, I got to keep. We got a lot of cases to go through.
Yeah, he doesn't really have a anterior listhesis much. It is evoked a little bit with some flexion there at 3-4.
Okay.
But it's not much of one. There's some facet arthropathy.
Is this acute fracture?
No, not an acute fracture. I don't think. I think it's probably a Schwartz node or insufficiency fracture. More insufficiency fracture,
Why?
probably. Well, you can see right in the center, like right above the 3 on the other image. You can see how it kind of looks like it dips down even more in, sort of. And I would expect that to be sort of where the nucleus pulposa is going in. But there is though also a little bit of wedging to the vertebral body. So
And also look at this. Like this almost looks like an osteophyte, doesn't it? In the front. Maybe not. So how about the MR?
the MR makes it look more. Well, it's too deep for a Schwartz node, I think. So I think it probably is a superior end plate insufficiency fracture. The malalignment there at L3-4, there's a little bit of anterior listhesis there, but there is also spinal canal stenosis at the L3, L4 level. You can see a lot of the CSF being up above, say, posterior to L2. You can see how much CSF is there anterior to the nerves, and down at the 3-4 level, there's virtually none.
Yeah, very little fluid there, and kind of similar findings.
Similar findings, not quite as severe at 4-5. And then here, the bottom left image well shows how the facets and the thickened ligament are really causing moderate canal stenosis there. And on the right image there, there's even a synovial cyst there on the left facet, right there, that with the thickened ligament that is contributing to cause that spinal canal stenosis.
So pretty stenotic, very little fluid around the nerve roots as
Yes.
compared to here, which is just above. And kind of similar findings here, wouldn't you say?
Similar but not as severe, yeah.
So here's the above. You can see how wide
open
open.
it is.
So this person, because of the spondylolisthesis, I felt needed to be fused so that I can widely decompress them as well, not worry about it. And so this is a classic case of stenosis with facet abnormalities only and 2 levels of spondylolisthesis. So what are your thoughts here, Joanne? This is a 47-year-old woman now with low back pain and bilateral L5 radiculopathy.
So here you again have the grade 1, grade 2.
Yeah.
Or
And
marginal.
why is it, look at the sacrum, is that normal looking
No,
sacrum?
that looks dysplastic.
Yeah, so it's a dysplastic sacrum, isn't it? So is it easy, do you think, to grade it in these cases compared to like if it's flat?
Yeah, there's a little bit more guesswork, I'm assuming.
It's kind of hard, yeah. So how would you guess? I mean, it's usually just kind of like, I mean, is that the front? That should be the front of the sacrum if it's a normal sacrum.
Yeah.
But that's like just a huge osteophyte that's developed over years, probably.
I just give the distance typically.
Where do you put your dot? Do you put your dot here, or do you
No, I
put
do
your
it
dot
at the
here?
back, where you did it.
Okay,
I
here.
did it at the back.
I know, but you have to have a relative distance. In
I
other
guess-
words, where's the front of the sacrum? Is that the front of the sacrum,
Well,
or is
if
that
you're
the front of the sacrum?
Assuming that in a normal person, the AP distance of the sacral plate is the same as the AP distance of the inferior L5 end plate, you could
Just
somewhat-
like this, right?
Yeah, you could somewhat estimate that it should be, if you're going to use a fraction, you could use that distance.
To guess. Well, I would say, in my mind, if I had to guess, like if I had to be an artist, and I would say that's where it should be. That's the front. But anyway, so the point being, it's dysplastic, isn't it?
It's dysplastic,
And
there's,
is this through the facets, or is it through the...
that looks like a Parse fracture.
Looks like a Parse fracture, doesn't it? And here's the posterior elements. They're left behind. They're like, hey, where'd you guys go? So, similar findings. And what are your thoughts here, Joanne?
So again, the anterolithsis of L5 on S1, the disc is clearly abnormal. It's extending posteriorly as well. The end plates are.
How would you describe this disc herniation? I know Adam likes to use the word unroof. Do you use the word unroof?
I don't typically use that word.
No? Okay.
I just ball it all together in a disc osteophyte complex, and I describe the shape of it because that's hopefully what you need to know in terms of how it's potentially impacting.
How would you describe this shape? Like a dumbbell? What would you
How
say?
would I describe it? I would say circumferential disc osteophyte complex, and then based on the axial images, describe its posterior contour as to how it could. I mean, because the anterior aspect of the disc, I usually don't get very eloquent about because that's probably not potentially going to impact anything. The posterior aspect is going to
Okay.
impact.
Surgical decisions.
Yeah.
So how would you describe that?
Um,
This is L5S1.
Boy, so you have. So clearly the central canal is elongated, and there are extensive hypertrophic changes along the posterior elements. I'd like to see the degree. I mean, the degree of central stenosis does not look that significant, but
Looks
I would
pretty
like to
wide open, right?
Yeah, I would
Look at
like to see how the lateral recesses and the foramen look inferiorly to that. I mean, there's clearly hypertrophic changes about the facets, and the
Yeah.
question is whether it's impacting anything of meaning to you.
Okay, well, just clinically, she has L5 radiculopathy. So even if I can't see it on the MRI, I know it's going on,
Okay.
and it's obvious the problem. So just the surgery is. Remember, you said it's different if there's a Parse fracture. It definitely is. If there's a Parse fracture, here there's a wad of callus. Here's this. This is like an excellent artist's rendition of the problem. And see this massive ball of callus that's hitting your 5 root from the fracture. So you put this in the facet, twist it, take this whole bone off. That's called a gill laminectomy, and then decompress this entire root. And that's really hard to do because it's a massive wad of bone and callus that's been forming in blood vessels. But you have to do that if you want the pain to go away, and it takes a long time. And it takes 40 minutes or something, which is sort of a longish type time because this is a long operation. But you have to do it, especially if you want to reduce it, because if you reduce the spondylolisthesis, the nerve gets trapped, so everything shifts. And if there's like a spike here, they'll compress the nerve root. So you have to constantly keep, this is sacral, constantly keep looking at it intra-op. So that's just more of the case. So this is the post-op CT, and I can tell you the X-ray, I couldn't see anything. So here's the pre-op, and I had to get a CAT scan to see if I reduced her or not. I couldn't tell from the X-ray because she was kind of a big body habitus. But you can see she's perfectly reduced, which is, you don't have to reduce these, but it increases the probability for things to go well and fuse and everything.
I'm usually surprised how, I think like you said, you don't have to reduce them. Most of the time it seems to me they don't get reduced. And my thought is, if it is that loose, just, can you yank it back? How much
You can.
can you?
You can.
But I guess your thought is, again, if you haven't cleared the hole enough when you yank it back.
Well, I'll tell you why you can't yank it back, because like in this case, she had a bilateral L5 radiculopathy for 6 months. So when you yank it back, you're actually stretching the nerve. So think about it. The pelvis, the spine is in the pelvis, and the nerve runs down the foot. So you're actually pulling backwards on the spine, and you stretch the nerve.
Yeah.
So in a big deformity, you can stretch the nerve a couple centimeters, and the nerves don't tolerate it.
Yeah.
And so that's why they get a radiculopathy, and it's a problem.
Wouldn't, if you're pushing the sacrum relatively forward, wouldn't that be shortening the distance the nerve travels?
No, that's not how it
Does
works. You
guys
pull the
hamstring?
L5 backwards. You pull L5 backwards.
you
That's how
pull
it works. Yeah,
Okay.
yeah. It's hard for
You
you.
don't push
It's,
the sacrum forward.
no, the sacrum is kind of still. The pelvis is kind of still, and you pull the spine backwards. That's how it works. So I'll show you. You get,
Yeah.
it's forwards like that, and you pull L5 backwards. And by pulling L5 backwards, you stretch the L5 nerve root,
Okay.
because it's tethered at the pedicle on the bone, and it stretches. This is just
And that eventually
it resolved completely. She was kind of a youngish woman. She's 30.
She looked young from the remainder of her vertebral body.
Yeah, she was like 30. She did well, and then I took her back 1 week later, and I plugged a piece of bone here to increase the fusion mass and decrease the stress on these screws. Because whenever you reduce something, it always wants to go back to where it used to be, because everything's stretched. So I think this decreases the probability of failure by putting a big block of bone there. And I did it 1 week later. I usually stage these cases because I think it's less stressful. Here's the AP. So, okay, so here's another case, Adam. This is these are 2 cases I did this week. So these are kind of relevant to me and Eric because we just did them. 62-year-old man with low back pain and left leg pain, and he's had a previous L4, L5 fusion 4 years ago. What do you see here?
Well, he has been fixed, posterior fixation at 4-5. 5-1 disc is narrowed, but the alignment looks pretty good. But 3 is anteriorly listhesis on L4 by a few millimeters. Posterior elements there look pretty decent. I doubt if there's a Parse Fracture. And there's a scoliosis, however, also, which is contributing to his problems.
Is 2-3 normal?
No. 2 is anterior listhesis on 3 as well.
How about 1-2?
Good. A little narrowed, but good.
Okay. And he has a history of gout too, by the way. So here, I won't get into this. This is the canal, the spine and spinal canal above.
Looks pretty open.
Okay, pretty open. And look at this facet. Is that a normal facet?
It's hypertrophy.
So, can you comment on these views? That's a standing view on the left, and that's an extension view on the right.
With extension at 2-3, he reduces, and 3-4 standing, he looks better. There's perhaps a little reduction, but not as much as at 2-3.
So the problems in my mind for this man is that his gravity line, which is here, it goes through your head, T1, T12, and it should be here. And it's pitched anteriorly, so he's pitched forwards. And L3 should be L3 normally should be horizontal to the ground, and he's 28 degrees going downwards. So that's putting a lot of shear force on him. So the question that we had is, do we have to do an osteotomy? Do we have to cut the spine to straighten it out so that he stands straight? Do we have to cut a portion of the bone? And then what osteotomies do we do? Do we just cut through the facets? And if you cut through the facets, you get somewhere between 10 and 15 degrees at each facet. Or do we do a pedicle subtraction osteotomy, which is a much larger surgery? It's an additional hour and a half of surgery with significant neurological risks. but you get 30 degrees out of that, maybe 30, 40, maybe you can get up to like 60. You get a lot out of a PSO, pedicle subtraction osteotomy. So that was in our thoughts pre-op. So what do you think here, Adam? Do you think he's fused?
No. I'm looking at the bottom left image. At 4-5, there's perhaps some bone going through there at the disc space. The window level's not quite right. But
How about here?
I think at the facet, there's some fusion there. And the bottom center image, again, it's hard to tell with that window level, but I would think there's some fusion.
Okay, look at this facet. Is that, you think, normal?
No, it's very wide, and the angle is abnormal.
Very wide, right? Okay. And you think he's fused?
Not completely. See, that is 5-1, and the 4-5.
So this is I'm calling this 4-5, if you don't mind.
There's some fusion, yes.
Okay. You're stingy with the fusion diagnosis, aren't you? So this is 1-2. Is this a normal? What do you think of this facet?
The angle is too anterior posterior. It's not oblique enough, and it's hypertrophied a little bit.
And how about that's very interesting that you picked that up, because it spins. Then the thoracic is has to spin all the way. So he's got a very sagittally aligned facet. And so what do you think of
Those are wide.
2-3 wide?
Yeah.
This is 2-3. How about 3-4?
Also wide.
Very widened and
That looks solid.
solid fusion, right?
Yeah.
So okay. So why do you think it's widened?
I think like the case you showed, one or two cases before, where when he's weight bearing, which is not when he's on the CT scanner, he subluxes.
Right.
And when he reduces it, and that causes that space to widen out.
Okay, so I did a T-lift on him. I know because I did the surgery. A T-lift is a translumbar interbody fusion. When you cut this, and then within the disc space, you stick a piece of bone. In his case, I put a piece of ilium, and you can see how that fused. But through a T-lift, you can't fuse the whole disc space like you really can if you put a block of femoral allograft in the front. But this is a case of a T-lift, translumbar interbody fusion, where he put an interbody graft from the backside into the front, and he fused that. So this, I think, is his main problem, was the spondylolisthesis and the severely degenerated facets. And I just want to keep rolling because we're running out of time. But this is another example. Now you can see the facets on the MRIs where they're gapped. And we know the CAT scans, the X-rays, the MRI scans. So it gives you an idea of how sloppy his spine is.
Can I mention one more
yeah,
thing, going back
sure.
two images, like go back to one more back. One more, sorry.
Okay.
On the right-hand side of the screen, he's got some transitional anatomy.
Yeah, it's a sacrum, yeah.
Yeah, and so he's
sacralized here, yeah.
And so, in your opinion, I mean, I'm on the fence about waxing eloquently about some of this stuff and how to describe it, but
I would say sacralized transverse process of L5.
But do you see more pathology when people are lopsided?
Yeah. So L4, L5 in this
Yes.
man we call it the first mobile segment.
But
so
only on one side.
He's fused on the other side. You just can't see it.
Okay. All right.
So
Or fused to a less extent, or
somewhere else. He doesn't move.
Predisposed to.
Yeah,
subsequent-
it's possible. Yeah, but it makes it very, very stiff. Basically, that level doesn't move. It's like a piece of the pelvis. So intraop, we got a lot of reduction to his facets, and through the hardware. So we got 37 degrees. So we felt that was sufficient, and not to do the pedicle subtraction osteotomy, which is a lot less surgery for him, and fewer risks.
Do people reduce as much when they're prone as they do when they're supine?
Yeah, I think so. And through the implants, you can suck. Basically, you make the rod proud, like you put the rod here, and then you suck the screw up to the rod through the instrumentation. That's how you reduce the spondylolisthesis. But you have to do it slow because you can pull the screw out. So whenever I do it, Eric always says, "You're going to pull the screw out." It's like, no, I'm not. It's like, so it can happen. Okay, so Joanne, what do you think of this case? 57-year-old woman with leg pain, left leg pain, and low back pain.
Okay, so she's got grade 1 antral listhesis of L3 on L4 and grade 1